Then we have now a session on international health systems compared. We have two presenters in this session. The first one is Cristina Hernández-Quevedo. Cristina is from Gran Canaria. That is the that is the first thing I want to say. She is from Gran Canaria, but she is working in London for the last 17 years now. Okay, she's working at the WHO Observatory of Health Systems and Policies. And so she is in charge of many reports from the observatory, and she's broad spectrum. If she were an antibiotic, she would be a broad spectrum researcher. Okay, so she will be talking on, well, I don't have the title here, but it doesn't matter. That is a comparison on health systems in Europe. Okay, that is the focus of her presentation. Okay.
Hello, good morning, everyone. Can you hear me well? Okay. I'm going to start. I think it's slightly easier for me in this way. I want to start thanking the organizers of the event, the International University Menéndez Pelayo, the Center Ernest Duke, to have me on board. Of course, Beatriz González and Vicente Ortún for inviting me to participate in this event. And it's a great pleasure as well to share this session with Sarah Thomson, that she will come after me. She has been actually my boss at, at the observatory for a while, so it's very nice to catch up with her as well. And as mentioned, today I'm going to present on health systems and their comparison, how we use it to inform policy in the European context. And this is very much linked to my job at the European Observatory on health systems and policies. So what I'm going to do in my presentation, because it's linked, ultimately it's linked with the observatory role, is to give you a context of international comparison of health systems, going into what is the observatory, what it does, and the core pillars of the observatory work. Okay, and specifically on country monitoring. I'm going to provide you an example on data use for international comparison, as well as results that we have gathered. In this case, in particular, I'm going to use Spain in the European context. And then I'm going to give you some insights on the key ongoing reforms in Europe, following a reform tracker that is a new tool that the observatory has as well, to end up with some highlights and key messages. And I hope an excellent interaction with you. I think I'm more a learner than another thing, given your profiles, but it would be really nice to have this exchange. So to start with, because I think it's going to contextualize the relevance of country comparison. So regarding what is the observatory and what it does, so we have to go back like 25 years ago in Europe in the early 90s. So actually at that time, there were several new Central and Eastern European countries that were emerging after the dissolution of the Soviet Union. There were around 15 countries. But then there were other European countries such as Romania, I'm going to give this example, that they inherited that Soviet Union type of health system that is more centralized, etc. And they wanted to transform into a health insurance system, for example. Then we have in Western Europe health systems that were facing high costs, and there was increasing expectations from their citizens on the provision, and this had to lead to health system reforms. So, for example, in the early 90s, we had in France, they were approving the Universal Healthcare Act. No? So they were doing as well reforms. So, but at that time, what happened is that there was not enough evidence on these reforms, how they could impact the different countries, and also these new emerging countries. So just to give you an example, in 1986, it was signed by the WHO countries from Europe, the Ljubljana Charter on Reforming Healthcare, which is highlighting and gives you a framework for health system comparison. So this is shows you the relevance and the importance of health reform at that time. So in 1988, the Observatory was created, hosted by WHO, but also with Norway and other international organizations, besides the academic institutions in London. Just to give you an insight that our partners have evolved over time. So it's a mix of, we are hosted by WHO Europe. We have as well international organizations such as the European Commission and a range of governments, the Health Foundation that you can see it as a think tank, and then LSE, LSHTM in London, and they are aiming to build bridges between evidence and policymakers. So that's the main aim of the observatory and the partners. So the observatory provides to the countries through 4 functions. And these 4 functions are country monitoring, that is the one I'm going to discuss further. Then there is the second pillar of policy analysis, performance assessment, and knowledge transfer. And at the end of the day, knowledge transfer is cross-cutting to the previous categories, because what we want to reach is to inform policymakers. So I want to give you, this is an example of the observatory output formats and their audience. So we can provide more general evidence for a general policy audience, and these are related with the country monitoring work that I will show you a bit in more detail later. So we have the HITS, the Health in Action, the HSPM network, the state of health country profiles. We also publish articles, but then the evidence, if you want to reach policymakers, it has to be tailored to the specific needs and requests. So one example are the policy dialogues. These are organized events with stakeholders. And for example, if a country is interested in implementing a specific reform, we sit different policy makers from other countries to give their insights on how to perform this reform and an assessment of that reform. So going forward to what country monitoring is and how it can help. Let me have a bit of water first. So when we discuss about country monitoring, it's about capturing and analyzing what is happening across Europe in the health systems and the changes that are taking place. And what it allows you, when you compare with other countries, it allows to see your own health system in the context of a comparative context, international context with other countries, and learn as well from other countries' experience, right? So what we want is, and we use country monitoring to examine the different approaches in different fields in the health systems, the organization, their financing, the delivery of health systems, and the role of actors. For that, it helps, so country monitoring as a tool for disseminating the information, the exchange, as I mentioned before, of reform experiences between policymakers, identify these emerging trends in reforms, and they highlight the challenges and areas that require more detailed analysis. For that purpose, in the case of the observatory, what we do, and for country monitoring to help out this comparison, we need a template. So for each of the products, the reports that we produce, we try to use the same template for all countries that facilitate the comparison. We will see later with the example of Spain that you have to be wary of the data and what the data tells you. And when we do country monitoring, we have to be aware that we need to combine both the quantitative and the qualitative information. Because if we use only quantitative information, you miss that complexity of health systems, and you need to capture the process and what is going behind a number, and I hope you will see it as well in the example for Spain. This is an article from some of my colleagues that you could access, and it tells you that the relevance of giving this qualitative explanation to the data to understand what is happening in the health system. But for that, in the case of the observatory and the data that I'm going to show you, so we use a network of experts, and you can access here our health systems and policy monitor network. And here you will find, so we work with different institutions. In Spain, for example, is IACS, that is based in Zaragoza, you may know them already, and we have policy updates and country updates on the health system. And in this way, and we work with them in the different reports to provide this evidence. Okay, so we need that expertise as well from the academy. Just, I can give you more details later if you are interested. You can also check it in the Observatory website. But just to let you know that the information I'm going to use for the specific case of Spain, it would be the HITS or health system reviews. This is the flagship of the European Observatory, and these are well-known. They are books, they are reports, but they look like books. Then we have the health system summaries that are slightly shorter. We have health systems in action that cover those countries that are out of the European Union. So if you are interested, for example, for Ukraine or here North Macedonia, so you have the report. We have some snapshots on how health contributes to the economy as well. And the state of health country health profiles that we do together with the OECD, that is one of the products from the data that I'm going to present, it comes from this source. And this is something we do because the European Commission requests it each 2 years. And we are working in a new edition, which data will be updated shortly. So it will be available November, December. But this version that I'm going to use today for Spanish health system in the European context is from 2023. And as mentioned, I'm going to focus for this part to contextualize Spain. I'm going to use the health system review that is published in 2024. It's led by Enrique Bernal Delgado, but you also have Rosa Urbanos that will be later joining. The state of health, as I mentioned, and the platform with all the information. So for you to have all the sources of the data. So let's start with Spain in the international context. So let's start with health status. So I have selected a range of indicators that we show in this material that I think it could give you some insights on where is Spain and also the health system characteristics behind the different health systems. So here you can see, we know Spain has the highest life expectancy in the EU, and this has been increasing after the COVID pandemic. Actually, now it's in 84 again. So we have reached pre-pandemic levels, and is far away. Already at that time in 2022, it was farther from the European average, the EU average. What we see here, so just to mention, I'm not mentioning association or causality, but we have to see that in the lowest, those who have the lowest level of life expectancy, Romania, Latvia, Bulgaria, we're talking about countries that the health spending is quite low, even the lowest in the EU. We will see it later in a graph. These are quite hospital-centered health systems. In the case of Bulgaria, it doesn't help that they have the highest rate of smoking, highest rate of alcohol consumption. So this may be some issues behind these figures. Also, they have shortages of health professionals, so they have joint characteristics in these lower parts of the graph. And if you go to the highest levels of life expectancy, it's true that Sweden, Italy, they share our structure of national health system. Now, I selected this graph of the prevalence of main risk factors. At that time, we had data for 2019, the published work. Here you can see the rate of adult smoking, heavy drinking, and obesity in Spain. And you see that for smoking, slightly above the EU average, heavy drinking, much lower than the EU average, and in obesity for adults, is slightly lower than the EU average. I wanted to do the comparison with Sweden, because if you go here, you see that smoking, the percentage of adult smoking in Sweden is half the amount in Spain. Heavy drinking is quite high, and obesity is similar to Spain. So what's going on in Sweden? So we have to contextualize this. So here they have a tobacco policy that is a bit broader than the Spanish one, in the sense that they cannot smoke in public places like bus stops, terraces in bars and restaurants. Smoking is also ads on smoking and heavily banned, etc. And then in the case of heavy drinking, however, they have a structure where there is a monopoly that sells alcohol with high levels of alcohol. No? And the problem here is that at the end, it's not helping, despite that measure, to reduce alcohol consumption. It seems that heavy drinking is still high. So it may be due to behavioral patterns in the country, that there is a long tradition of consumption of alcohol, or because it's not so available as before, because you cannot buy it in a supermarket. It has to be in these specific places that they don't do discounts, they don't do awards, no, when you do points because you buy more. So it may have actually a bad effect in heavy drinking. When we move to health system financing, I don't want to go too further on this because this is Sarah's expertise, so I'm sure she will go in deep into this. But when we do the international comparison of Spain, what we see is that health spending, public health spending in Spain is smaller than the EU average. This lighter color has to do with private spending and out-of-pocket payments, and you see it's quite high. However, what happened in Spain is that although out-of-pocket payments at that time were around 20%, there are large exemptions, and they don't make households poorer, right? So we are protected somehow of these out-of-pocket payments. Again, as I show you with life expectancy earlier, here you have this set of countries with very low health spending, and then other countries with very high health spending compared with Spain, such as Germany, Norway, Austria, Netherlands, etc. Now, is this the whole picture? So one potential additional indicator that we could use is whether actually there is value for money. So when we do the graph between treatable mortality is that mortality that you can treat with actual care and diagnostics, right? And health spending per capita, here we see that in Spain, with a certain amount of spending per capita, we really have a very small, it's actually one of the smallest treatable mortalities in the EU. So we get very good results. In the case, for example, of Germany, they use very high level of resources, and then treatable mortality is higher than in the case of Spain. So it seems, maybe this is not the whole story, but according to this graph, that actually in Spain, with the resources that we have, we are getting good outputs. Of course, this is linked with the use of primary care and primary care in the core of the health system as well. Now, if we move to resources, what I'm doing is like giving you a bit of an insight on each of the issues regarding a health system. And now, following to number of practicing medical doctors, we see in Spain, if we see the trend, they have increased over time, and the same for nurses. But there has been some studies, and Beatriz and colleagues have a forecasting article for the ministry that shows that there would be a point where future needs of health professionals may not be covered. So actually here, and it's one of the issues I wanted to raise regarding data. So Spain is a place where doctors are high and nurses are low. And as mentioned in the previous presentation, here we are not capturing the nurses that are technical nurses in the survey. So, and they may be doing the same activities than other nurses in other countries. So this may be underrepresented somehow. So we have to be careful with what we are interpreting. Then I wanted to show you, for example, the case of Portugal. So in the case of Portugal, again, we have it with a high number of doctors and a low number of nurses. And the problem in Portugal is with doctors, because when you go to the statistics, they capture both all licensed doctors. So it's not only those who practice, but all that are licensed. So actually, there may be overestimated here. Okay, so besides giving a graph and a comparative international indicator, you have to be careful on what you are capturing in the data. I wanted to show you that despite that, in any case, countries with high number of doctors, such as Portugal, or in this case, Spain, and low number of doctors and nurses, such as Romania, they have a problem of migration. So doctors have left the country. They have done a reform in 2017. They have tripled their salary, and they still have an issue with that. So, and France, that is in the middle, but they all share the same problem. And it's like some areas are underserved. So there are not enough interest in practicing in a specific area. So in the case of France, there is a long story of the under-desert areas that they are called. In Spain, it has been shown that there are some shortages of GPs in certain areas. And similar happens in Portugal, where the inland area of the country has issues with coverage of the population because of lack of GPs. And there have been different reforms over time, and this has not been fully successful. Now, when we go to provision, and this is just to give you an insight of primary care, so we know I didn't want to be discussing about primary care in Spain. You know, it's the core of the health system, and they have a gatekeeper role. But when we go to any of the countries, so this is a specific box that we include in the different hits, like for Denmark, UK, France, they have the same problem. So they have a GP that is at the core of the health system, and they have this gatekeeping issue, but they have an issue with the geographical variation in the densities of GPs. And this has an impact on the accessibility of primary care services for the population. So it's a joint challenge in health systems. I hope I'm going well on time. Now, what happens if we go to unmet needs that have to do with the accessibility of the health system? When we check for medical care in Spain, unmet needs, just in case you are not familiar with the concept, is those who need medical care and they don't get it because of costs, because it's not available, waiting times, etc. So these are very small in Spain, unmet needs for medical care. But when we go for dental care, these are very large. And the larger is the difference across income quintiles from the poorest and the richest. But as you see, again, this is a challenge shared by an important number of countries, including Denmark, Finland, France, Romania, Latvia, Greece. Very large inequalities in access to dental care. And I didn't want to miss, in the sense of the provision of healthcare, mental health care. So the Eurofund is a survey that it was done during the COVID pandemic, and we have data for 2021, 2022 at that time that we published those reports. And in Spain, the idea was that unmet healthcare needs during the pandemic were 18% similar to the EU average. So these are people who needed medical care and they didn't get it. But then when you are reflecting which of these needs were for mental health care, so in Spain they were around 20%, slightly smaller than in the EU of 22%. I have to tell you that in the writing of the new report, these unmet needs have increased very much. You will see. But I wanted to compare you these results with Latvia, for example. So again, the need to combine these quantitative figures with the qualitative information. So if we see in the case of Latvia, we see that unmet needs for medical care are very high, nearly double double the Spanish ones. But then when we go for mental health care, only 8% reported that they need they needed mental health care and they got it. So maybe you could say it's more accessible mental health care in Latvia than in Spain or similar. Of course, there is something social. Probably mental health care is not as a sensitive issue such as in Spain. Maybe there is stigma. Maybe what is relevant is actually the healthcare needs, not the mental health need. There may be many reasons behind that result, but I wanted just to show you as an example of the importance of giving a background to the results. Now, to finalize, I wanted to give you some insights on the health reform tracker that I mentioned before that I persuade you to use. So it's at the European Observatory website. And here you can choose which area you are interested to analyze and the year. And it will tell you which reforms are taking place in the different countries. This has a methodology, so we work with this network of experts and they choose which are the 3 top reforms in their country. Okay, so there may be something missing because we are only considering the most relevant according to the experts. And there is in YouTube, there is a webinar that explains perfectly how it works. Reinhard Bus is behind this as well, and his team, and you will see how it works, but just to let you know. So what happens, and I'm going to give you some insight, is just to show you that after the COVID pandemic, so reforms were in different lines, but one very important, it was the development of digital health. So until there was no maybe even regulation on it or use of it. So in yellow, all the countries that have measures on that. Here you have some examples, as simple as the electronic prescriptions that maybe in Spain are more developed and in Austria they didn't, or national guidelines for delivering telemedicine services. In Spain, we had even a new General Secretary for Digital Health created in United Kingdom for hospitals. So this was a strong pillar after the COVID pandemic, one of the main reforms in Europe. Then, of course, on public health, so after the COVID pandemic, there was a need to establish all those reforms that have been left aside, and also to be prepared for the next potential pandemics. So there is a range, because here we are considering, and depending on the year, you will see different legislations, so even national screening programs, national vaccination strategies. So a country like Romania, they have this issue of people don't believe in vaccines and they have very small rate of vaccination. Then we have, for example, in Spain, the idea of the public agency that hasn't been approved yet. So a range of measures that were taking place on public health in Europe. And in terms of financing, there was also like a wave of increasing coverage after the COVID pandemic. And here you just have some examples, but There was some, for example, expanding newborn screening program in Norway, fertility treatments for a second child. Well, in Spain, we had the increase in dental health, etc. So, I mean, there were several measures taken on coverage. Just to mention that all these reforms in Europe, these trends, are linked to the national plans or strategies that have been in place in Spain. So we have seen them related to public health, to primary care, to mental health, and dental care. That is the one with the most limited access. So just, I don't know how I think I'm nearly there. In terms of key messages, I hope I went very quick in the last part, but just want to, I hope you have taken these ideas that country monitoring work allows policymakers to compare the health system in an international context and see the strengths and the weaknesses of the country. That international comparisons require this background of qualitative evidence to tackle all these complexities of the health systems. And then the responses from the health system after COVID-19 pandemic, I think they have been general, also, of course, associated with the national plans and the funding, focusing on governance, public health, coverage, and digital health. And in preparedness, because countries were not prepared for the challenges. And the common challenges remain. I haven't gone in detail here, but well, we have seen something related to the distribution of health professionals. So this is an issue that many reforms have been put in place, but still remains important. Then we have the issue of inequities in dental care. That is always like forgotten. And then the inefficient use of resources and the value for money. So I will leave it here. I think it has been half an hour. Thank you so much. It would be great to have your experience as well on data use, on whether this type of international comparison helps you in your daily work at all, or how you want to see the data, how it can be helpful for policy making as well. Bueno, any exchange, I'm happy to discuss. Thank you.
We have some time now, okay, for questions, suggestions, comments, what you want. Okay. So, someone? Okay. Wait a moment. Yeah.
Oh, thank you. Are you aware? Thank you for the presentation. And I would like to know if you are aware in your observatory position of the situation of Spain, which has been described before you speak. Do you know really? Are you aware of all the details and all the problems we have here?
So in a way,
In Spain and probably in other countries, I don't know if you have the possibility from time to time to approach really health makers and
I think, yeah, in the observatory there are two parts. I will say two parts. I will say it simplified. So we produce this background work. This is what it's used to sit with policymakers and discuss potential policies and improvements, etc. So, for example, me, I sit in the background information. So we do all these reports together with academics, but we also have policy experts in the area. Everything is cross-checked a few times. Just to let you know that there is interaction with all in the countries. We don't go directly to the country, except the second part of the observatory, that is the top, that they sit with policymakers and they discuss. Usually, as I mentioned, there is the policy dialogues, and in this type of format, we have all stakeholders. So if for a specific topic, we have civil society, but we have policymakers from the country, we have policymakers from other countries to give their insights on how it works, etc. So that's how the approach that we have.
Okay. More? I have a question, okay? So I think you are doing a great job and very useful. And my question is, beyond the description of the health systems and the reforms, etc., can you go further in the causal relationship between cause and effect, and to infer with data the effectiveness of the policies, or you have some kind of limit because of the political correction? I mean, are you free to disclose all your everything you get, or you have some limits?
I think from my experience, I think it would be good to have Josep, Josep Figueras, maybe you know him, and he's Catalan as well. And I think he was dealing with all policy makers, and I'm sure he will have all these stories not to tell you. Well, it happened to us that we provide one Spanish hit with its authors, very neutral, we understood, and the ministry was not happy with it. So we sat with the ministry and they were not happy with how it had been provided. I mean, we try to gather, the evidence that we provide has to be neutral, and to avoid any, because of these complexities that we are not aware. But when something is with evidence, we cannot remove it. So I think we are very cautious. Maybe Sarah can give you more insights as well on how they deal in WHO in Barcelona, but we are very cautious in the language we use. We try to be as much as possible close to the data, and but of course there are some nuances, no? That maybe they can give you, okay, you are not taking this into account, but completely forbidding a publication. In my case, it hasn't been the case. Maybe there is some some example, and I don't know, but we have published it.
Okay. More questions, comments, suggestions? Yeah, Natalia.
Thank you, Cristina. Very inspiring, as you always are. Just adding on Bea's question, then how do you deal with this part of the portfolio that I won't remember the name exactly, but I think it's like specific requests that you get. And do you develop the same kind of analysis in the same way for these specific requests, or it is different because they have, I guess, a higher political implication than just the summaries on health systems?
So, for example, what we do from usually what we are requested from countries is what is called a rapid response. So usually they have a question and they need a quick response, like we need to fill a report and we want you to, for example, for the case of Spain, when they were considering the public health agency, they requested us a quick report on other public health agencies in Europe. So we put it together. For that, we usually have very little time. So if it's a very short question, maybe 1 week. If we have a bit more time and we can do a proper report, we have a bit more time. The issue here is that some of these requests, although we submit and they are useful for their purposes, they can become a study. So there is a point, imagine that they are requesting you some evidence on health inequalities and how to tackle what other countries are doing on health inequalities, etc. And at the end, it ends up being a long study that we start inviting experts from different countries and writing chapters. And at the end, you have so there is a range of products depending on this, but we try to be very quick on our requests. Yeah.
Okay, so we are now going to the next presentation, but we will have time after this session to discuss all together, okay, with both researchers. Thank you, Cristina. So now, Sarah Thomson. Sarah was the former boss of Cristina. of the European Observatory of Health Systems and Policy, but now she's in Barcelona in the WHO Barcelona Office for Health Systems Financing. In fact, she's an expert in health systems financing with a lot of publications on that. Okay, so she's going to talk hard work. Look, this suggestive title: hard work for government, balancing public and private financing for UHC in Europe. Okay, thank you.
Thank you very much, Bea. Thank you for inviting me, Vicente and Bea. I'm very happy to be here. My name is Sarah Thomson, and I work for the WHO Barcelona Office for Health Systems Financing, and we are very generously funded and supported by the Generalitat de Catalunya. So thank you very much to the Autonomous Community of Catalonia for the funding provided for the office. We are part of WHO Europe, and we work across the 53 member states in the European region. So we don't focus on Spain, we focus on a huge range of countries. But today I'm going to focus geographically on the European Union member states, the 27 member states of the European Union. I'm going to be talking on about health financing, health systems financing, so how we get money to pay for the healthcare that we all want and that sometimes we all need. And I'm going to be looking at Europe and European experience. I'm going to be talking about health financing for universal health coverage. This is the objective that health systems across Europe have committed to through many, many international declarations, including at the level of the EU through the social pillar of rights in the European Union as well. And universal health coverage means that everyone should be able to have access to the quality healthcare that they need without experiencing financial hardship. And I'm going to be focusing on financing with these goals in mind, but also focusing a little bit on coverage policy and how countries ensure that this is what happens. And we know already from the outset that to do this requires two things. First of all, it requires predominantly public spending on health, so spending that comes through taxes, through social health insurance contributions from the government budget, public money. But it also requires very carefully designed coverage policy. And Manuel de Castillo, when he was speaking earlier this morning, touched a little bit on coverage policy, and I'm going to focus on that a bit more. But just looking at the trends in health spending, in public spending on health across the European Union, let's look back to 2000, for example. Between 2000 and 2008, there was a really big expansion in public spending on health. There was a big expansion in coverage policy. So countries were feeling that they had money to invest publicly in their health systems, and they were expanding coverage, improving access for the population. And then what happens in 2008? We have the crisis, right? You're all familiar, especially in Spain, you're all familiar with this. The global financial crisis followed by economic crisis in countries. And many countries in Europe have a very difficult time and cut public spending on health. Many, but not all. Spain was one of the hardest hit countries, but other countries were not so badly hit. And then we have the period, let's say, between 2015 and 2019, where there's a period of recovery from the real challenges that the economic crisis provided for many countries. There's a bit of recovery, and then in 2020, the pandemic hits. And actually, because it's a health shock, and there was some learning from the global financial crisis before, countries are quick to invest more in health systems in response to the pandemic. And then now we have a situation where I think after the pandemic, after the increase in public spending on health, ministries of finance have a little bit of health fatigue. There's a feeling that health got a lot of money in the pandemic, and now there are other priorities, there are other challenges. There's inflation, there's the war in Ukraine, energy prices increasing, and pressure now with different politicians in America, in the White House, pressure to increase defense spending. And there's a feeling that maybe there's health systems are going to face a real challenge now and in the years immediately to come, in the medium term, possibly the longer term as well. So this is the context that we're facing now. It's in one way, it's quite a bleak context internationally, globally. So some people think that maybe this is a time to look for alternatives to public spending on healthcare. And I just wanted to begin by asking you guys, you all know, you're very experienced in the health sector here. Is this something that you hear in your daily life, or something that you think that maybe we should be doing? Is it time to explore alternatives to public spending on health? A show of hands, something you're thinking about, something you think that it's possible to do it. It's time for governments to think outside of the box, think a bit differently, or you think that basically the governments should continue to do what they're doing, at least on the financing side of things. Maybe you're all, oh yeah, we have somebody brave willing to put his head above the parapet. Please go, oh, is there a microphone?
Total spending on healthcare is likely to increase because this is related with income elasticity and economic development. What is not so clear is that tax should go to the same road than in the past, because some of the things that they are now consider healthcare expenditure are not so much blockbusters, are not so much related with externalities. It's not so much public health. It has to do a lot about convenience of the different individuals. For the reason I'm not sure with so much difficulty in increasing tax rates, it makes sense to go head by head, total healthcare expenditure and total increase of public expenditure, basically financed by taxation. This is my caveat about.
Okay, thank you. So maybe you were saying that total spending may increase, but maybe the government share of that maybe it won't keep pace with total spending, because maybe there are some things that we're spending on now that we could spend less on in future. Let's see. So thank you very much for that comment. So this is, I have 5 parts in my talk today, and these are the 5 things that I'm going to be talking about. First of all, health financing is boring. I want you all to be aware of this from the beginning. My job is very boring. Second, employment-based financing is history. The third part is going to be looking at, so these are 2 parts looking at spending on health, financing health systems, and then looking at coverage policy. Third, are medicines actually healthcare? Maybe this comes back to your question, Guillaume. Fourth, why are medicines free inside hospital but not outside hospital? And then finally, looking at the role of private health insurance or voluntary health insurance, I'm going to ask the question, what's wrong with Ireland? So this is what I'm going to cover very quickly in the next half an hour. So health financing is boring. Poor me, I have a very dull job. It is boring because we really know what works when it comes to financing health systems to meet the goals of universal health coverage, right? If you have different goals for your health system, then maybe what I'm going to say is not relevant to you. But if countries want to meet the goals of universal health coverage and making sure that everybody can has access to healthcare without financial hardship, then health financing is boring because we know what works. Just as a quick recap, the different mechanisms countries can use to get money into the health system here are moving from payment at the point of use, so out-of-pocket payments, including co-payments, copagos, to prepayment, so you pay before you need to use healthcare, thinking that you will need to use healthcare at some time, to risk pooling, where different risks of people are put together in a pool, and I pay money that I may not spend on myself, but may go to spend for your healthcare. And the more that we move along this spectrum from payment at the point of use to prepayment to risk pooling, the more likely we are to meet the goals of universal health coverage. And it is the prepayment plus the risk pooling that gives you the insurance function that all health systems aim to provide people. So health systems are not just for improving health, but they're making sure that people can access healthcare and improve their health without experiencing financial hardship. So the more you move towards the green side of things, towards the goals of universal health coverage, the more you need to rely on taxes, including social health insurance contributions. So we know this from a lot of empirical literature. It's very boring. There aren't really very easy alternatives to this. We know that more public spending on health means that countries rely less on out-of-pocket payments. These are the private payments that you pay at the point of using healthcare. And on the vertical axis here, you have out-of-pocket payments as a share of total spending on health or current spending on health. And on the vertical axis, you have public spending on health as a share of national income, a share of GDP. And you can see that there's a pretty strong relationship between these two things. The more a country spends publicly, the less it spends out of pocket. And Spain really sitting right on the line here. This is among EU countries. So more public spending means lower out-of-pocket payments. Many countries in the EU still rely very heavily on out-of-pocket payments. So this country shows you the breakdown of total spending on health across the EU 27 member states. And the red at the top is out-of-pocket payments. The yellow in the middle is private health insurance, and the green is public spending on health, so government or social health insurance. And you can see Spain, countries are ranked based on how the share of government spending and total spending in Spain is actually quite far to the right of this chart. But we'll see that Spain does pretty well with this distribution of total spending on health. But a lot of countries rely quite heavily on out-of-pocket payments. You can see at this end of the chart here. Why does this matter? It matters because we know that financial hardship, so we measure financial hardship using indicators like impoverishing health spending, so whether people paying out of pocket are pushed into poverty or further into poverty because they have to pay out of pocket. And we also look at catastrophic health spending, which is where households have to pay out of pocket more than 40% out of pocket, more than 40% of their capacity to pay for healthcare. So of their disposable income after we've subtracted a very small amount to cover basic food, basic heating, electricity, gas, utilities, and basic housing costs. If people spend more than 40% of that money that they have left through out-of-pocket payments, then we say that they have catastrophic spending on health. And what this chart shows you here, this is again for the EU countries. This is work that we've done in the Barcelona office, for the WHO Barcelona office. The incidence of catastrophic spending is quite closely linked to how much a health system relies on out-of-pocket payments. And we have this line here, which is 15% of out-of-pocket payments, so 15% of total spending coming through out-of-pocket payments. And we can see that below this, countries generally have quite a low incidence of catastrophic health spending. So it's on this axis, catastrophic health spending, on this axis, out-of-pocket payments as a share of total spending on health. But as you spend more out-of-pocket, you rely more heavily on out-of-pocket payments, the financial hardship for households really increases. Spain doing pretty well, even though you have let's say 20% of your budget, or your health spending comes from out-of-pocket payments. It's doing quite well in terms of having quite a low incidence of catastrophic health spending. And that really reflects very strong coverage policy in Spain. So the whole population, more or less the whole population is covered. The use of co-payments is quite limited. But there is there are several gaps in coverage, which we'll come on to in my session, but also I think later today. So it's important. Public spending matters because the more you spend publicly as a share of total spending, the less financial hardship there is for households. But policy also matters because we can see that there are some countries that have, like Spain. If you look at Spain here and Estonia here, a similar share of out-of-pocket payments, but very different results in terms of catastrophic health spending. And again, that reflects the differences in coverage policy across these two countries. So what aspects of policy are we interested? What do we need to know in order to make policies that can actually reduce reliance on out-of-pocket payments, but also reduce catastrophic health spending? And the data that we have collected across countries shows that this is, again, the light blue is the incidence of catastrophic spending across countries, Spain doing quite well. But the dark blue is the incidence in the poorest fifth of the population. You can see that the distribution is very unequal. And in all of these countries, the incidence of catastrophic health spending is much higher in households with the lowest incomes, the poorest fifth of the population. Nothing very surprising there, but it's very systematically monitored, and it shows that this is very consistent across countries. So to improve financial protection for households, focusing on households with low incomes is a key policy message here. And the second policy message is what kinds of services should we be focusing on if we want to improve coverage, access, financial protection for households. And this shows you among the households with catastrophic health spending, this is what they're spending their out-of-pocket payments on. And the red is medicines, and then you have in orange medical products. And this is often things like glasses. I can see several of you wearing glasses. I have contact lenses. If I didn't have glasses or contact lenses, I would find it difficult to move from this side of the room to the other side of the room. And then dental care in blue. So this is also a gap in coverage in many countries. And then outpatient care yellow, inpatient care green, diagnostic tests purple. These last three things, diagnostic tests, inpatient care, outpatient care, these are not, in most countries, these are not driving financial hardship because these things are usually well covered by the health system. It's really medicines in countries with weak financial protection and in countries with stronger financial protection. The gap is for dental care that Cristina pointed out in her talk, but also for these things like glasses for people who have vision problems. So I think one of the interesting findings is that we tend to think that out-of-pocket payments that are catastrophic must be because people are spending a lot of money on something that's really expensive, like cancer medicines or inpatient treatment. But no, what we see is that actually it's probably quite small amounts that people are paying out of pocket, but that are large in relation to people's capacity to pay for healthcare. So a low amount through out-of-pocket payments, probably through co-payments, for medicines, for dental care, for medical products, but because it's falling on people with low incomes, it's leading to financial hardship. So it's really treatment in primary care settings. So we often think that in Spain, we probably feel very proud of the health system and the primary care driven aspect of the health system, particularly here in Catalonia. But actually there are gaps in coverage in the treatment of primary care in many countries across Europe, and Spain is one of those countries. And then if we just, again, importantly, to look at the poorest households, we can see that medicines are really a much bigger driver of catastrophic health spending in poorer households in every country. But even in countries like Spain, still it's medical products, dental care that are creating financial hardship for households with low incomes. So I've showed you why public spending on health matters, because the less you spend publicly, the more you spend out of pocket. And that creates financial hardship, particularly when there are gaps in coverage of medicines and medical products like glasses and dental care. But it's important not to forget about unmet need, and this is what Cristina talked about. We would see, this is a chart for Lithuania, and I show it because it's very clear from this chart what it's showing. So this is catastrophic health spending. The bars are catastrophic health spending by type of care, from the poorest households to the richest households. And the dots are showing you the instance of unmet need for healthcare. So it looks like dental care it's really a problem for rich people when it comes to financial hardship. It's not such a problem for poor households. That's how it looks. But it's because the poorest households are experiencing higher levels of unmet need for healthcare. Some of them simply cannot afford to pay out of pocket, and so they don't have access to dental care. And so it's very important to look at catastrophic health spending and unmet need together and understand that when it comes to things like dental care, probably it's richer people who are able to pay, and some of them may experience financial hardship, but poor people simply just don't have access at all. So health financing is boring because we really know what works if we are wanting to make progress to universal health coverage. It's predominant reliance on public spending, focusing on people with lower incomes and trying to improve coverage for things like medicines in particular, but also dental care and things like glasses. But is all public spending on health the same? And I can ask you, let me show you. This chart shows you the breakdown of public spending on health, depending on the type of financing scheme. And you see some countries like Spain are predominantly in the dark green, and this is because they are predominantly financed through the government budget. So we would refer to this as a government scheme. But then there are a lot of other countries like France, like Luxembourg, Belgium, that have social health insurance schemes. So SHI here refers to social health insurance, where people who are working pay social health insurance contributions, which are basically a tax. It's compulsory, it's a tax, but it's levied on wages. It's paid on your salary. And these countries here in light green rely very heavily on these wage-based social health insurance contributions to finance the health system. So my question to you is, do you think that we see differences? Does it matter, this difference between government scheme or social health insurance scheme? What do you think? Would we expect to see differences in performance across these two different types of health system? Does it matter? What do you think? Any responses? I come from the UK, where we are, actually the UK is not here because sadly the UK is no longer a part of the European Union, but the UK would be with Spain, right? So a country that's really financed by the government budget. And in the UK, we have a lot of problems with the health system. When you have something, it can work amazingly well, like the Spanish health system, but there are problems with waiting times and access to GPs and other things. And often politicians will think, well, wouldn't it be nice if we had the French system? People in the UK love to talk about the French health system. The French health system does very, very well. There's this feeling that if we change to a social health insurance scheme like in France, all our problems in the health system would disappear overnight. And I wonder if you have any of that kind of debate here in Spain, maybe? Looking at other countries, looking at the way other countries finance their health system and thinking, if only we were like Germany, or if only we were like France. No, maybe you are more mature in Spain than politicians in the UK. That could be possible. Broadly speaking, when we look at differences across countries in terms of performance, in terms of how much they spend on health, in terms of how much unmet need there is, in terms of how much financial hardship there is because of out-of-pocket payments, we don't see systematic differences between these two different types of financing scheme. So it doesn't really matter. And this is another reason why health financing is boring. Financing the health system is boring. It doesn't really matter if you have a social health insurance scheme or if you have a health system that's financed through the budget on these big, important indicators that we're thinking of. It doesn't really matter. But there's one area where it does make a difference now, and when you face a shock of some kind, and also in the future, thinking about the aging of the population, and that is the revenue base. So I told you that social health insurance contributions, the revenue base is usually wages, and that's quite a narrow revenue base, and it's particularly vulnerable to economic shocks, because if you have an economic crisis and unemployment suddenly goes up and wages are going down, but your health system relies on income from wages, that's a shock to your health system, and you will lose revenue pretty quickly overnight. Of course, the government budget will also lose revenue as a whole, and politicians may cut the health budget. That happened in many countries that were financed through budgets during the crisis. So having government financing is not a guarantee. But in employment-based systems, it is the revenue base is very cyclical. So as the economy goes up, you may get more revenue. As the economy goes down, you may get less revenue. So it's very cyclical. It's in line with the economic cycle. And it's also at risk from population aging. And I want to show you just some results very quickly from a study that we've done recently, looking at the impact of population aging on public revenue for the health system and spending, and financial hardship, catastrophic health spending. And we looked at 5 countries, because those that we thought were sort of typical across Europe, but also where we had age-related health spending data. And I'm not going to go into big details here, but I want to just show you the example of Spain and compare with Slovenia, 2 countries that we looked at. So we took age-related, we looked at the age structure of the population, how it's going to change in the future. And then we looked at age-related health spending, and you know that health spending generally is higher for people at older ages. And then we looked at, if we don't change health spending, but we just change the age mix of the population as it's projected to change, to get older, what is the gap in public spending on health caused by this aging-related shift, this demographic shift? And what happens if instead of public spending growing, as it has grown in the past, that gap is filled through out-of-pocket payments? How would this affect the incidence of catastrophic health spending? And I'm just going to focus on the results we got for Slovenia, which is a small country in Eastern Europe, and Spain, a large country in Western Europe. And so we looked at the situation between 2022 basically to 2060, looking at the age shift in the population, and then looking at current spending patterns and how there would be a gap, how it would affect the gap in health expenditure, which is the dark blue, and the revenue for the health system, which is the light blue. And Slovenia, so Spain is here, money from the government budget. Slovenia is here, some money from the government budget. All health systems rely on the budget to some extent, but really heavily reliant on these social health insurance contributions. And you can see that this is the size of the gap, the aging-related gap across Slovenia and Spain. Overall, the gap is roughly the same size in these two countries. It's quite large, but it's really heavily driven by revenue in Slovenia. So this means that because Slovenia relies on employment to finance its health system, the health revenue will shrink by 10% between 2022 and 2060, just because the population is aging. More people are out of work than in work because they're older, they're pensioners, they're retired. Whereas in Spain, which relies on the government budget, it's a much broader revenue base, taking into account other types of income, VAT, property taxes, and so on. And you can see that for Spain, there is no impact on the revenue side at all. So a really big difference here. So social health insurance contributions levied on wages are really vulnerable to population aging. And we see this across other countries in Europe, not just Slovenia, but other countries that rely on employment to finance their healthcare. So this is the one area where I would say that the kind of revenue base you have does make a difference for the performance of the health system. And then we looked at what would happen if the gap that you see here, this gap is filled through out-of-pocket payments. And you can see that in both Slovenia and Spain, the starting point is very good, very low incidence of catastrophic health spending. But if out-of-pocket payments increase, the catastrophic health spending is forecast to increase by quite a lot in these two countries as well. So just because Spain and Slovenia are doing well in terms of financial protection today does not mean that they will continue to do well in the future. And that countries need to really work to, not Spain, because you have a broad revenue base, but countries like Slovenia really need to broaden their revenue base if they're not going to experience this catastrophic spending shock that you see here. So relying on employment to finance healthcare, it reflects history in many countries. So it's quite hard to change in many countries, but there are examples of countries that do it. And if we have time in the discussion afterwards, I can talk to you about the experience of France and so on. But probably it's not so relevant to Spain because you have a budget-based financing system which already captures a broad revenue base. And I think my message here is don't move away from that. Don't be tempted by these. I don't know if you've had this expression in Catalan or Spanish of a red herring, but in English we say don't be distracted by the red herring. It's just there to take your attention off what you should really be focusing on, which is the things that Manuel del Castillo talked about this morning. Health financing, how you get money into the health system, should be really boring, but there is a lot of scope for reforms on when you're thinking about what it is that you do with that money, how you spend it to purchase healthcare, for example, and to ensure that people have good quality healthcare. There's a lot of improvement and spectrum for reform and change there, but when it comes to health financing, it needs to be boring. Okay. I've spent 20 minutes talking about health financing, and I'm just going to take 15 minutes now to talk about coverage policy, which is the other side of the coin. We need public money, but that public money needs to be spent really well and carefully designed through your coverage policy to make sure that the people who need healthcare are the ones that are actually getting the healthcare. So very, very quickly, this segment, it's literally 1 minute. Are medicines actually healthcare? And who here thinks that medicines are not part of healthcare? Anybody think that medicines Who thinks that medicines are healthcare? Yeah. Okay, good. You're still awake. We all think that medicines are healthcare, right? We've all had medicines, and medicines have helped us and improved our health. But I asked this quite facetious question because I will allow me to laugh at my own country here. So this is the NHS in England. The British people are very proud of the NHS. This is the Prime Minister, Keir Starmer, and the Secretary of State for Health, Wes Streeting. And they are talking about how proud they are of the performance of the NHS. It says, for decades, the NHS has served us well with the enduring principle that everyone should get healthcare that is free at the point of use. And in the UK, we are very proud of the fact that this healthcare is free at the point of use, that everybody gets healthcare that is free. But in reality, it's not true that healthcare is free, that all healthcare is free, because we have to pay. Cristina knows this because she's been living there for 17 years. You have to pay for your medicines, you have to pay for dental care, you have to pay for glasses, contact lenses. So there are lots of things that, and we have all agreed that we think that medicines are healthcare that are actually not free at the point of use in the UK. So it's interesting that the government, everybody thinks that it's free, but actually there are many things that are not free. And just before you think, well, this is the UK, they're an odd, an unusual country, they don't want to belong to any important groups. This is the case in a whole range of countries. There are lots of countries that claim that primary healthcare, for example, is free because primary care visits are free. So this is from our study of 40 countries in Europe. This is where the types of healthcare are covered at all, and luckily mostly they are covered. And then whether they're covered but with co-payments, and that's the yellow bit, and this is the percentage of countries. So in many countries, not all, but in many countries, primary care visits are free, and that's the case in Spain, in Catalonia too. You don't pay anything for emergency care or for primary care visits. But the minute that you need some kind of treatment in primary care, the minute you have a problem with your teeth, with your eyes, or you need medicines, then those are the things that people have to pay for. So if primary care treatment is not free, can we actually say that primary care is free? And the implication here is that maybe some of the things that we think are healthcare are not really healthcare. Of course, I'm just being facetious here. But it is interesting that many countries limit the coverage of treatment in primary care. So you can go and see a doctor. Everybody thinks it's important for people to have access to a doctor. But the minute the doctor says you need a medicine, or you have a problem with your teeth, or you have a problem with your eyesight, we make people pay for those things. And I think the question is why that should be the case. So just a very short reminder to you that medicines, dental care, glasses should be seen as part of treatment in primary healthcare and should be part of the benefits package. Some provision for people, maybe not for everybody, going back to Guillem's point here, but some basic provision for everybody. And I think that Spain is moving in the right direction on this, but it has been an important gap in coverage in Spain. Okay, fourth part. Why, thinking about medicines, and I'm going to focus on medicines here, because this is where the co-payments are, this is where the coverage is, with dental care, generally weakest in European health systems. Why are medicines free inside hospital, but not outside hospital? And I have another question for you. So how many of you have been in hospital and had to pay for the medicine that you received while you were an inpatient in hospital? Did anybody here been in hospital? I have been in hospital here. I didn't have to pay for medicines in hospital. No. Did you have to pay for medicines in hospital? No. How many people here, and I include myself, have had to pay for medicines outside hospital? Some of you have either know people who are giving you free medicines or have very good health. But most of us, when we need medicines outside hospital, we have to pay for them. And my provocative question here is, what's the difference between a medicine in hospital and a medicine outside hospital? So this is the share, again, showing you something that I've just showed you in a previous slide for 40 countries here, just focusing on EU countries. This is the countries with co-payments for different types of healthcare. And you can see that when it comes to medicines in hospital, only 2 countries make people pay for medicines in hospital, and they're Belgium and the Netherlands, if you're interested. So most of us would go to countries and not pay for medicines in hospitals. GP visits, about half of countries have co-payments. Inpatient care, more countries have co-payments. But then when it comes to outpatient medicines, every country has co-payments for outpatient medicines, except Malta. But Malta doesn't cover co-payments for everybody. They just cover co-payments if you are very, very poor or if you have some chronic conditions. It's a very unusual country where they don't actually cover medicines for the whole population. Every other EU country covers medicines for everybody, but they love to make people pay for medicines at the point of use. And most countries love to have percentage co-payments for medicines also, much more than for other types of healthcare. This is where you pay a percentage of the cost of the medicine. And here in Spain, you have that kind of system where, I mean, I'd be interested to know how many people actually know how much the medicine costs, what percentage you're paying, and so on. That's something we can talk about maybe in the coffee break. So a lot of countries charging people for medicines in an outpatient setting. And the question is why countries really like to do this. And I just want to show you the impact this has on financial hardship. So we looked at coverage policy for medicines in 27 EU countries. And based on microdata from these countries, we predicted the probability of having catastrophic spending. And under 2 different scenarios, the probability of households having, the share of households with catastrophic health spending was 19% in one scenario and 2% in another. And what made the difference here? Well, on this side, you had countries with co-payments for medicines, often percentage co-payments, where you pay a percentage of the cost. And there were very few mechanisms to protect people from these co-payments. Whereas in these countries, you have co-payments for medicines. I showed you 26 out of 27 countries have co-payments. But you have protections from co-payments, so exemptions. So some people don't have to pay the co-payment, or there's a cap. You limit how much people have to pay. And ideally, that cap is linked to income. So we are not saying here that countries should not have any co-payments, but we are saying that if you have co-payments, think about the design of those co-payments. Pay attention to this, because if you have a careful, protective design, you can really lower the risk of financial hardship for households. And unfortunately, many countries, for various reasons, don't pay enough attention to this, and you end up with a lot of things that are complicated. So I'm just going to go very, very quickly through the protection mechanisms that are important. But because this is not such a huge issue in Spain, I will just go over this very, very quickly, and then I'll go on to the last bit, which is looking at private health insurance. So it's just important that co-payment design is simple. You want to avoid complex co-payments that are really designed to protect the budget and not thinking about what it's like to be a user. So I know that when I was in hospital here, and I would get my medicines in hospital for free, my outpatient medicines in hospital for free, but I also needed other medicines, and I would go to the pharmacy. And I genuinely had no idea when I went to the pharmacy how much I would be paying in co-payments. No idea. You look at I had a long list of medicines, and I would think, is it going to be €4 or 400 euros? I have no idea. And then the pharmacy would tell you, and you pay, and so on. But that's very unclear. And I have a job and I have a salary, and it was not a problem for me financially. But if you are somebody with a very low income, maybe there is some uncertainty about how much you're going to have to pay. And that's why a cap is very, very important. There are different prices of co-payments that are very lacking in transparency for people. And if you have co-payments, it's probably better to just have a fixed co-payment. So people know that it's €1 per prescription or per medicine, or €2 or whatever it is. But you know that if you have one medicine, it's going to be €1. If you have 2 or 3 medicines, it's going to be €2 or 3 in total. There's some kind of financial certainty for you. So that can really help people, particularly with low incomes, people with chronic conditions who have regular use of medicines. I won't spend time on this because we have a great policy brief, but it just shows you how a change in the type of medicine for diabetes, type of co-payment from fixed co-payment to percentage co-payment in Finland had a really significant impact on access and financial hardship. So small change in type of copayment really hurt people, and also didn't address the root cause of why diabetes medicines were increasing in Finland in the first place. So instead of tackling the clinical guidelines which promoted newer, more expensive diabetes medicines, they decided to shift the costs onto households and make the households bear the extra costs. They didn't think about controlling the doctors, they just thought about putting the costs on the patient. If you're going to protect anybody from co-payments, it should be households with low incomes and people who have chronic conditions. And I think that in Spain, you have very good protection for households who are older, who have to pay co-payments. But it doesn't really make sense that households who are younger and are working, who also have low incomes, have to pay more in co-payments than people who are older. So I think I know that the government also is looking at this, trying to make better protection for people with people of working age, younger people, because those are the people that actually experience financial hardship, according to the study that we did on Spain. So it's just important that you're targeting the right people with your exemptions, and that you have a cap that benefits not just pensioners, but everybody at some point. And if you link the cap to income, then that means that it softens the budget impact. So you're not saying that everybody has the same cap, but people who have low incomes have a different cap. And again, some examples of an income-based cap applied to the whole population in Austria, with a very important impact on financial protection there. And then just the final point on protections, that they should be automatic. So it shouldn't be that you have to spend money first and then you have to apply for protection. No, it should be automatic in the pharmacy. And I think actually that happens in Spain. But again, another policy brief looking at the experience of what happens when you use IT, digital solutions to make protection automatic. It exponentially increases the take-up. So co-payments are present in all EU health systems, more or less. They're not really very good at addressing low-value care. So I think that if countries are concerned about inappropriate use of healthcare, it's really important to look at the supply side and not think about the patients as a solution to this problem, because most of what's happening in health systems is driven by what's happening on the supply side, and just important lessons about how to protect people from co-payments. Okay, finally, last 5 minutes, private health insurance. What's wrong with Ireland? So many countries think, actually, we have out-of-pocket payments, we have co-payments, but it would be really nice if we could get voluntary or private health insurance to cover those out-of-pocket payments, because you saw from one of my first slides that private health insurance involves prepayment, and it involves some risk pooling, and it's therefore much better in terms of meeting the UHC goals that I mentioned than out-of-pocket payments, which are just at the time of use, there's no prepayment, there's no risk pooling, and so on. So what about private health insurance? Could that fill the gaps in public spending on health? Again, this shows you the EU countries. The yellow bar is the percentage of the population covered by private health insurance, and then the red dot is private health insurance as a share of total spending on health. And the first thing to see here is that, one, there's a lot of variation across countries, so it's very hard to talk about private health insurance as one thing. It's very, very context, very system dependent. It's very different in every country. In most countries, it hardly covers anybody. In a lot of these countries here, it's under 10% of the population. There are only a few countries where it covers a significant share of the population. And in terms of spending, in most countries, it's like 1%. In most countries, it's well under 5% of current spending. So it's not really filling a big gap. It's not really eating up those out-of-pocket payments. It's really, the spending is very low. I've highlighted Ireland and Slovenia and France as the 3 countries where it's more than 10%. In each of these countries, it's around 13% of total spending on health. But in all the other countries, it's very, very small. So it's a lot of variation across countries. And private health insurance plays different roles in these countries. And you can see that in the countries that have, where it really contributes to spending on health, Slovenia and France here, it's used to cover co-payments. So these countries have very high percentage co-payments, including for inpatient care. You pay 20% of the cost of inpatient care if you don't have insurance. It's a very strong incentive for people to buy insurance, and very high levels of population coverage because in France, actually, since 2016, it's been mandatory for employees to offer private health insurance to their employers, to offer private health insurance to their employers, and to pay for 50% of the cost of the premium. So employment is picking up a big part of this spending here in France. And in Slovenia also, it was very heavily regulated, and that's why you see very high levels of take-up. But this is very, very unusual across the EU. And in fact, in 2024, Slovenia abolished co-payments in its health system. It abolished almost all co-payments, just overnight, from one day to the next. And it literally overnight, it wiped out the market for voluntary health insurance. And now there's almost no private health insurance. So for 2024, this would be 0.001, and the population coverage would be around 5%. I'm going to focus on Ireland because I think Ireland has the private health insurance market that is most similar to the kind of private health insurance that you have here in Spain, where it's really providing people with faster access to usually elective, to outpatient specialists or inpatient care for elective procedures. Unusually, in Ireland, it covers a lot of people and it makes a big dent in public spending on health. So what's so unusual about Ireland, and would Spain, where is Spain here, want to move from here to be more like Ireland? So there are some predictable challenges with a voluntary health insurance market, and we see this across countries that it does exacerbate inequality because it's generally richer people who are able to afford this than poorer people. Whether that's a problem for policy or not depends on how big this is. If it's 10% of the population, or 20% with this, maybe it's not such a big problem. But if it's 50% of the population that has this and 50% without, maybe that's a political challenge for health systems. And my message here is that the bigger private health insurance of this type, providing faster access to healthcare, gets, the more it has an impact on the publicly financed part of the system. It adds to complexity, it has human resources implications, it draws doctors, nurses, other people from the public sector to the private sector, and ultimately it can have a negative impact on publicly financed coverage. But that's if it's big. If it's very small, covering 5-10% of the population, it probably doesn't make such a difference. So Ireland, what's wrong with Ireland? So a very high share of the population has private health insurance, providing faster access to hospitals. There are historical reasons for this. So in 1957, richer people did not have coverage for hospitals. They were not covered at all. So they had to buy voluntary or private health insurance. So because these people were not covered by the government said, okay, you can buy private insurance and we'll help you. We'll give you some tax subsidy to buy private health insurance. We'll cover, say, 20% of the premium cost for you. At this point, private health insurance starts to use private beds in public hospitals. So it's not that private insurance is using private hospitals, it's using private beds in public hospitals. Also, providers have an incentive to treat these privately financed patients because they get paid more when they see these patients. And you guys, you can see what's going to happen here. In 1991, the government says, okay, we're an anomaly in Europe because we're not covering richer people for hospital care. Every other country in Europe provides universal hospital care. So we're going to cover richer people. At this point, there's an increase in demand for public hospital beds because now these rich people have access to hospital beds. Because of these incentives in the system, there's also pressure on public hospitals. So there's a lot of pressure on the public hospitals and the waiting times really start to increase. The waiting times increase, and previously it was just rich people who bought private health insurance, but now because the waiting times are really high, everybody feels that they need private health insurance. I want private health insurance. You want private health insurance because we didn't want to wait 6 months, 12 months, 18 months, 24 months for something that we think that we need. the situation gets so bad by 2002 that the government starts to buy public healthcare from private hospitals because there's so much pressure on the public hospitals because of all these incentives in the system. The government starts to think, okay, let's have tax incentives for private hospitals, and let's also buy public healthcare from private hospitals at higher price than they are paying in the public hospitals. And so it continues, and this is like the perfect definition of a vicious circle. The government realizes it has a problem because it's paying people to buy private health insurance, which are taking up more beds in public hospitals, and so they cut some of the tax subsidies for private health insurance. Not all of them, but some. And then they do all these other things, some of them pushing people towards private health insurance, some of them pushing people away from private health insurance. On top of this, you have some legal challenges at national level and to do with EU law. So it's a complete mess. The government is in a terrible situation. Nobody is happy in this country. Nobody is happy. And the waiting times have really, really gone up. And the tax subsidies that the government is still providing for private health insurance mean that poor people are subsidizing better access to healthcare for richer people. 40% of the privately financed healthcare is actually provided in public hospitals. And you see the waiting times for public hospitals increase exponentially. We are all thinking at this point, some of you are probably thinking, what's wrong with Ireland? How can the government allow this situation to happen? And I think it's complicated. You can see here that actually there are very powerful interests here. So once you allow this situation to happen, to unfold, it's very difficult to walk back from that because you have private insurance companies that rely on this income and they don't want the market to shrink. You have public and private providers who rely on this income from private health insurance and they don't want the market to shrink. And you have a lot of richer people who have this better access to healthcare and they don't want private health insurance to be taken away from them. So it's a very difficult situation. Once you are in that situation, it's very difficult to get yourself out of it. It's not because there's something wrong fundamentally with the Irish. It's just that they didn't anticipate the interests as they were increasing the market. And by the time the market got really big, it became really difficult to address those initiatives. So voluntary health insurance, particularly this type of voluntary health insurance, it's fine if your health system has this, but it should be small. It's not something that the government should encourage to grow bigger, because as it grows bigger, the problems become exponentially bigger. We know from economic theory that it's difficult in a voluntary market to give access to everybody. And we just know from international experience that governments, this is a failure of public policy. Governments are not good at regulating private health insurance markets generally. And a lot of it is because they don't anticipate the challenges, they don't monitor what's happening, and by the time they realize there's a problem, it's difficult to address it. So if you have this kind of voluntary health insurance, keep it small. Definitely you should not subsidize it with tax subsidies. You want to keep it small and manageable. And if you want to have it covering co-payments, as France and Slovenia do and did, you can do that, but it's really hard work for government. There's a cost for government. The government is now paying half of the premiums for government employees. Employers are paying half of the premium for private sector employees. So it's expensive in terms of money, but also in terms of the complexity of the health system. And there's a lot of debate in France about how to change this system. So I'm going to stop here. This is my penultimate slide. Fixing private health insurance, it feels like it's going to be an easy option, but once it gets big, it's difficult to address the challenges. And it feels like you're letting the tail of the dog wag the dog. I don't know if any of you have seen this movie. It's an old film. It's about a sex scandal in the White House, and it's about a spin doctor who comes and he actually he pretends that there's a war in Albania in order to distract the media from this sex scandal. So just don't be looking at other things, other alternatives. Think about focusing on the publicly financed bit of the system. This film is apparently swift and hilarious, very funny. it's very slow and it's very boring to focus on what's happening in the publicly financed part of the health system, but that is where the improvements are going to come from. This slow and boring work, this work of improving the purchasing that Manuel del Castillo was talking about this morning. It's not sexy, it's not fun, but it is where the improvement is going to come from, the better quality and the better access to healthcare. So try and resist red herrings. There's no easy alternative to public spending on healthcare. But not all public spending is the same, so think about making sure that you continue with budget spending that has a broad base and it's better able to deal with different types of economic, health, aging shocks. And focus on coverage policy before you get to the purchasing that Manuel del Castillo talked about. It can be redesigned to boost resilience. If your system is prepared, if you are already protecting people with low incomes, then when a shock happens, you're in a much better place to address it. So really focusing on protecting people with low incomes, particularly from co-payments, making sure they have access to dental care, glasses, the things that we all need and benefit from is important. Okay, thank you so much for your patience. I'm going to stop there.
Thank you very much. What interesting. Wow. So, we have now about 45 minutes, right? And then I would like, well, thank you very much. Impressive both. But now we are going first, before the dialogue, we are going to introduce yourselves, okay? So I will ask you one by one to introduce himself or herself, just with just who are you and where are you working, and maybe some note on why are you here. Okay, so Jaume, please.
I'm Jaume Puig from UPF Barcelona School of Management, economist.
My name is Judith Guzman. I also have some experience in academia on health economics.
Uh-huh.
I'm Jaume Monclús, and I'm actually finishing my bachelor's in economics at UPF.
I'm Natalia Pascual. I work for Jaume Puig at UPF Barcelona School of Management. I'm health economist, but I'm political scientist by background.
Vicente Ortún, Department of Economic and Business, and CRES, and that's all.
Ferriol Soria, I'm the director of the Ernest Lluch Foundation.
So now, okay.
I'm Simone Leger. I am a pharmacist. I'm working with the foundation and mainly in the industry, the pharmaceutical industry.
I'm Roger Sabater. I'm a researcher at CRES, and I'm a PhD student at Universitat de Barcelona.
Sergi Sánchez. I work at Aquas, the Healthcare Evaluation and Quality and Evaluation Agency of Catalonia, and I kind of coordinated this course, like between the directors, foundation, QIM, and everyone.
Hello, I am Iciar de Lecuna. I am professor at the School of Medicine, a lawyer by training, and currently director of the Bioethics and Law Observatory, UNESCO Chair in Bioethics at the University of Barcelona. Thank you.
I am Mateu Huguet. I'm retired, but I was a former manager of health organizations.
Hello, I'm Cati Serra. I'm doctor. I'm director of 061, Servei d'Emergències Mèdiques, Catalunya.
My name is Tere Casasas. I nurse. I the emergency medical with Cati Serra.
My name is Daniel Marull. I work as a public health technician in the planification, let's say, the public department under the direction of primary healthcare.
Hello, I'm Jose Miguel Guzman. My formation is as biologist, but I work as a regional market access manager in pharmaceutical industry. And I am responsible for all this Catalonia and part of Spain.
Hi, good morning. Laura Diego, pharmacist by training. 15 years experience in the administration, and now in the pharmacy sector, Sanofi, working in public policy.
Hi, I'm Marcel Bach. I also was several years at Salut, at the Catalan healthcare system, right now working at the pharma industry also.
Hi, I'm Sofia. I am bioengineer, and I am now working also in pharma industry in health policy.
Guillem López Casasnovas, professor in public economics, Pompeu Fabra University.
My name is Maria Lazarov. I'm from Uruguay. I'm an economist, and I will be doing the Master of Health Economics in the UPF.
Hi, my name is Silvia Cortez. I have been working in finance, but now I'm training for working in the health sector, and it's a pleasure to be here with all of us. Thanks.
I am Xavier de las Cuevas, doctor in nephrology, now in this moment retired, assistant doctor, and working in homeless population in Barcelona.
Hi, my name is Albert Vives, Salut sense sostre, Barcelona.
My name is Rafa Manzanera. I'm retired too, as my two previous colleagues. I'm interested in health system and primary health care.
Hi, my name is Laia Llopart and I work as an economist at la Unió Catalana d'Hospitals.
Hi, my name is Jaime Pinilla and I work with Beatriz at the University of Las Palmas.
My name is Rafael Barba. I am retired too, a former manager in health and social organization.
Hortensia Aguado, nurse, in the moment to the team to Societat Catalana de Qualitat Assistencial.
Hello, my name is Aina. I work as an innovation project manager at Hospital del Mar, a hospital here in Barcelona.
Hi, my name is Montserrat Casamitjana. I'm retired. At the last years, I work in the Health Catalan service.
My name is Roser Casamitjana, and I am biochemical working in the Laboratory of Biology and Genetics of Clinical Hospital in Barcelona.
Hello, my name is Ángel Fernández. I am assistant professor in the Department of Applied Economics of the University of Granada. And my main research is health economics and health policy evaluation.
Okay, thank you very much. So maybe now we can have some comments or suggestions or questions for Sara, because she hasn't, and while Cristina had some. Okay, so Vicente, please.
Well, Sarah, thanks a lot for your presentation. I completely with avoiding the red herrings and focusing on public finance. But you have been living in Barcelona for 10, 12 years. You have listened Manuel del Castillo. We're about to reach 50% of the population with voluntary health insurance. Many people, few money, as you have shown in your slides. And my question is related. Yes, we should focus on public finances, but public authorities are also responsible for regulation. So my question is, which changes will you introduce on the regulation of voluntary health insurance in Spain? For example, do you think that it's convenient to establish a certified policy with the same benefits for everybody in order to make comparison easy for the people? By the way, I think that we are the most prevalent voluntary health insurance, but it is a non-supplementary health insurance. Perhaps it's something that shall be changed. Second, what will you do to avoid insuring people with voluntary health insurance just until they become seriously ill. Because if they become seriously ill, they should leave the system. The company start this year 5,000, next year 10,000, impossible. I have read in some of your books that you mention how in Germany, when you opt out from compulsory insurance and you go to voluntary, you need to go for all your life. So the amount of money that you pay should be computed in order to avoid what's happening now in Spain. That the insurance companies cover you until you become seriously ill. I think that the insurance policy should cover you until you are dead. This is the question. And any other suggestions about changing our voluntary health insurance policy, our regulation? That's all.
Thanks, Vicente, for that very simple question. So, this is a really challenging topic, and I think some of what I say, I think actually I didn't realize that the coverage here was 50%. So what does it cover? It covers faster access to treatment. It's quite similar to the Irish case, yeah. I didn't realize actually how relevant that the Irish case study would be for Catalonia, but I think there are a lot of lessons there. So you're proposing maybe to regulate the products. So one thing is that, yes, it's very confusing. It can be very confusing for people if they don't know what they're buying. And in Ireland, they did try and regulate so that there is a standard package so that everybody knows that at least they're getting covered for this much and that they could be able to compare the prices across companies. So that was a very important point of regulation in Ireland so that people could see, okay, I'm getting this package for 10 euros here, but here I can see it's 30 euros. And I know that it's the same package. I think what happens in most insurance markets is that you pay 10 here and you pay 30 here, and you don't know if actually it's the same coverage or you're paying for something different. So that was something that they tried in Ireland. They also tried very hard to have a community rated premium so that everybody, for the same package, everybody within one company had to pay the same premium. And then they tried to have a risk adjustment scheme, because if you start to have community rated premiums, then the insurance companies think, well, if I'm getting the same money for somebody who's 30 as I'm getting for somebody who's 50, or then you want to have somebody who's healthy. So the government felt, well, then we have to regulate for this, and we have to have a risk adjustment mechanism so that, and it became very complicated, and that's when you started to have the legal challenges, both at national level and at EU level, because the EU level says that if EU level, third non-life insurance directive says that if it's not substitutive, then the government doesn't really have the power to regulate the market. Interestingly, when the court case in Ireland went to the European Court of Justice, the Court of Justice ruled in favor of the Irish government, and it said that the Irish government could do whatever it liked in this respect. So I think that there is some uncertainty around the EU regulations here. I think that the opting out proposal, I'd say the Irish also tried to do this where they said, okay, if you need to buy private health insurance when you're young. If you don't buy it when you're young, then we're going to make you pay a higher premium for every year that you don't take it out. So they try to push people towards private health insurance on top of the... and ultimately, I think that the attempts were not successful in Ireland to do this, because they ended up actually increasing the size of a market. They were not clear in their heads what they wanted to do. And this is not to say that the Irish were crazy. There were a lot of interest at play. So it was not easy for the politicians to maneuver in this thing. And I'm sure that's the case here too, that the politics are very pressing. I think ultimately Canada had something very similar to Ireland, where they had long waiting times, and they tried in Canada to ban this kind of private health insurance because they knew that it would create problems for the health system. And there was a court challenge to the system in Canada. And again, in Canada, the Supreme Court ruled in favor of the government banning this type of market. These are not easy solutions. I think that there is just there should not be any, this is my perspective. I do think that it is a waste of public money to subsidize this kind of market, because you know that that money could be better spent in the public system. It's going to richer people. So I think that's one thing that's very clear. I think that if you have, what are the reasons that are pushing people to take up private health insurance? You need to address those. And in the end, it is the fact that people want to know that they will be able to see the doctor within a certain amount of time. So people aren't stupid when they buy these policies. They know what they're doing. And I think that in the end, that comes back to the red herring and the tail wagging the dog. In the end, the energy should be on making the publicly financed system better, so that people think, actually, I don't need to buy this insurance because I don't need it. My money would be better spent on something else. So I think there are no easy answers. You can try to regulate it so that it looks like publicly financed healthcare, but the risk is then that it gets bigger, or you cannot get rid of it because somehow people are locked into it. And I'm not sure if I answered your question. I think it's not an easy issue. And the politics just make this very, very challenging.
Thank you. Yes. Please.
Hi, here.
There. Sarah, there.
Yes, I wanted to know, when you ask, or do you know if other countries, regarding the financing of the system, the health system, do you consider other sources of finances that are not the people who receive the healthcare? Like, for example, taxing companies that sell alcohol or tobacco, or other companies that that doesn't contribute to the health of the people, just if other countries consider these other sources of financing.
Yeah, that's a great question. Yes, countries do tax things like alcohol, sugar, tobacco in particular, and use it to finance healthcare. In France, they tax all of these things, and they earmark that tax to finance healthcare. I think that this is ultimately, though, I think this is a public health question and not a health financing policy question. And I think that if you ask from a public health perspective, yes, countries should tax things that harm health, whether it's alcohol or tobacco or sugar or fizzy drinks, or whether it's things that damage the climate, because ultimately that damages health too. So I think, yes, from a public health perspective, countries should do this. With my WHO hat on, I say absolutely. From a health financing perspective, I think that in most countries, these types of taxes are a very small part of the budget. So yes, they can help, but they're not a magic solution to get a lot of extra revenue for the health system. And there's also, in the end, I didn't say this in my talk, but I implied it, that in the end, what matters for a sustainable and an adequate level of public spending on health is political commitment, political will. Because you can have tobacco taxes that come into the budget, and from one minute to the next, the government can decide, well, I'm going to cut this spending, or I'm going to spend it on defense. So ultimately, these taxes can play a role, but what matters is political commitment, and the government saying, I am committed to this level of public spending on health, or this level of performance of the health system, or to improving the health system, and that's how much I'm going to pay for it. So yes, they can play a role, but they may not be the magic solution for sustaining health systems.
Jaume?
Yes, Sarah, thanks for the presentation. I was not clear about the real message, the policy message of one of your slides. I refer to the one asking if medicines are actually healthcare. Could you elaborate more about that?
I was being a little bit facetious here. I think it was just sometimes people think that just observing the fact that medicines with dental care. So I could equally ask, is dental care healthcare? Because when you look at coverage of dental care and medicines, these are the things that are least publicly well covered in health systems, and people feel that people should have to pay out of pocket for dental care and for medicines. And there are lots of reasons for this, and partly it's history. So perhaps when health systems, publicly financed health systems, were established, medicines played a more limited role. There weren't such great medicines. Healthcare was really about either you're in hospital or you're going to see the doctor. And people felt that it was probably okay. We have a budget constraint. We can make people pay for medicines. And historically, that's why medicines have been something that all countries like to make people pay for. But maybe it's also an incentive effect where people think, well, perhaps there's inappropriate use of dental care or medicines, and that's why we want patients to pay part of the cost, because maybe that helps to address inappropriate use. And I think it's very valid to have concerns about inappropriate use. I think my question is whether it's appropriate to use co-payments to address that problem. And I think there's a lot of evidence that shows that when you have inappropriate use, it's because of what's happening on the supply side, and maybe co-payments are just not a good instrument for addressing those particular issues.
Then let me ask again the same thing, but in a different way, because your conclusion about co-payments, I think that is not in line with conclusions of the economic theory, but forget that. What's your proposal then? You are proposing just to eliminate all co-payments when using medicines, the same as when you are in a hospital?
So
Even reference
yeah.
pricing as avoidable co-payments, for example?
So on the co-payments, I think that, it's a provocative question. Why is it that medicines are provided free in hospital, but when you need them on an outpatient basis, countries, health systems think that people should have to pay for them? And my question is, I'm not saying that you should pay for medicines in hospital. I'm asking why you have to pay for medicines on an outpatient basis. I think that we're not saying that you should eliminate co-payments. I think just thinking about the design is important. So does it really make sense to make a person with a low income, who you are providing social support to with one hand, pay for a medicine that a doctor has told them that they need? Do we really think that the incentive effect is going to, what is the incentive effect there? And do we think that the incentive effect outweighs the effect of that person having unmet need or paying and experiencing financial hardship? I think that's the empirical question. So I'm not saying that you should eliminate co-payments, but just to think very carefully about who should pay them and who should not. Because for some people, it creates financial hardship. Even when the amount seems quite low to us, it can either be a barrier to access or it creates financial hardship and pushes people into poverty.
Okay, so now we open the floor to the general debate, also with Cristina, not only with Sarah, okay? I would start with a question that has to do with the classification of health systems, okay? Besides the classical classifications, Beveridge versus Bismarck, well, there is a recent publication by Health Foundation and the OECD that classifies OECD countries according to a cluster analysis with different variables. In that classification, Spain is in cluster number 7, with Finlandia, Portugal, and Costa Rica, and is characterized mainly by a strong public regulation, by a strong reliance on primary health system, primary care as gatekeeper, and third, with low choice by citizens, by patients, a low level of choice. Then what is your view on that? Do you think this is relevant? Do you think choice is important in a health system in this moment where patient is the center of everything and healthcare system based on values, etc., the prompts, all these kind of things? What do you think on that? Is choice important or not?
I can speak a bit on that issue. Well, just to mention, we don't have a specific report on patient choice, etc., but we know, for example, in UK, there is patient choice. And but then at the end of the day, when they are monitoring, because at the end of the day, it's focusing on waiting lists and simplify waiting lists and whether patient choice can reduce these waiting lists. And at the end of the day, when they report back on waiting lists, this has not been the leading issue. It has been the productivity, the focus on the productivity of the NHS, etc. So, yeah, this is my feedback from UK at this one.
So I think it's really important to be clear about choice of what. What is it that people want choice of? Is it choice of provider, healthcare provider, or is it choice of treatment,
Mm-hmm.
or is it choice of your insurance
Mm-hmm.
provider? And I think these are three very, very different things. And I think people may want choice of provider. So I think two things. One is what is it we're talking about in terms of choice, and then the second question is about whether there's an incentive effect here and whether we can use choice to improve the performance of the health system. And I think these two are related. So if you ask me as a patient in a health system, do I want choice of doctor? Maybe. What I want, though, what I really want is a competent doctor or a competent nurse and somebody who's also caring. So not just competent, but caring, thinking about me as a person. I think these would be very important for me. Do I want choice of treatment? And we know there's a lot of evidence that when you tell people what are the different treatment options that you have, people often choose things that are more cost effective for the system. So I think as a patient, I want information, yes, to make informed choices. Choice of purchaser, purchasing agencies, so having competition between insurance companies in a publicly financed system or in a privately financed system. I think the transaction costs here for the health system are really, really outweigh the benefits for the patient or for the health system. So I don't think, based on the empirical evidence, I would advocate giving people choice of insurance. Or, do you want public or private? Do you want this insurance company or this insurance company? So I definitely, just from an empirical perspective, would rule that out as having a positive effect on the health system. But choice of, I think people want good quality care, they want consistent care, they want patient-centered care. And if that comes with choice of provider, okay. But I'm not sure that choice of provider by itself is a great incentive to actually improve the performance of the health system.
I could just to add another example, the case of Sweden, that again they have introduced like patient choice, again to reduce waiting lists, and they have the same issue at the end in 2024. They had to put some other policies in place to reduce waiting lists because it's not working. So just as a tool to reduce waiting lists, it doesn't seem to be effective.
Exactly, but which doesn't mean that it's not a sensible policy, because of course, if one hospital has a long waiting list and the other hospital doesn't, then it makes total sense from an efficiency perspective to allow the patient to go to somewhere that has a shorter waiting list. So I think from a system perspective, that's a no-brainer. But as you say, it's probably not enough to address the waiting time issue on its own merits.
Okay, so questions or
just if yeah, go ahead.
Feel free to.
Couple of questions. Thank you for the presentations. Cristina, which is the added value of HITS versus OECD reports on healthcare?
Yeah.
Because at the end you are taking, well, I was looking at the same time you were talking about what the last report from OECD is 2024, and the data practically the same sources.
Yeah.
Why do we need this business machine now? And second, for Sarah, I have some disagreements, but it's not the time now for me to talk on them. But just to make sure a couple of things. Do you agree that payroll taxes are taxes by in the full
Of
sense?
course. Yes. Of course.
Okay.
Of
And
course.
second, the vouchers that civil servants have is voluntary health insurance, because otherwise your answer doesn't correspond with Vicente's question. And the third one, how do you see prices in public sector? For instance, how you would consider what the students pay in the university? Is that is out of pocket, but is voluntary?
So
we call them tasas. Probably at the time you have been used in in Spain you have seen that these taxes, these rates students are paying are going down, but at the end of the day, it's a public revenue.
Prices.
I'm not familiar with the tasas. So what is it exactly? Can you explain
What the
to me?
students pay in the university?
Public prices to
What the students pay in the universities, in the public universities in
tuition. The tuition.
Tuition fees
Yeah,
in
tuition
English.
fees.
How would you account for them? Out of pocket, by sure, but private, voluntary, compulsory.
I see. Well, my experience is on financing health systems and not financing education. But
If you put a fee on the utilization of the service, that it goes to increase the public revenue, nothing to do with private expenditure. How do you account for that?
so, I mean, I guess it's a fee, right? It's an out-of-pocket payment. It's the user pays.
Yes.
Yes.
It's an out of pocket, but sure, it's out of pocket.
Yes. I mean, yes, it is because the user pays.
It's public revenue.
But I understand that the university tuition fees here are very low compared to the UK, right? So in the UK, you pay £10,000 a year.
Once you have tuition fee, you
pay it. But it's I mean, yes, it's an out-of-pocket payment because it's the user who pays. If you don't go to university, you don't pay that payment. But there's a lot of government subsidy, so it's an out-of-pocket payment on top of government subsidy.
It's a public revenue.
It's public revenue, yeah.
Okay. It helps to increase public expenditure. We believe it helps to increase public expenditure.
Why?
Because with these fees, the universities or the public health system who pay better salaries to the doctors. It goes to the public sources of revenues, doesn't go private.
Right. So I'm not saying that all out-of-pocket payments are bad, right? Because
what I'm saying is, how do you account for fees in the public sector going to increase public revenues for higher public expenditure? This is my point. How do you account for them?
In the education sector. Yeah, so I'm not saying that countries should not have out-of-pocket payments that complement public spending on health, because out-of-pocket payments go to government spending on health also. The NHS gets 1% of it. In England, the NHS gets 1% of its revenue from co-payments. So all publicly financed health systems have revenue that comes from households at the point of use through out-of-pocket payments. So I'm not saying that health systems should not have this. I'm just saying that you want to look at who is paying those out-of-pocket payments and what effect those out-of-pocket payments are having on households. So it's the distribution that is very important. I'm not sure if that answers your question.
The point is, should they increase?
What, for university education?
No.
Oh, for health?
To introduce fees in the healthcare sector, whether we should increase these copays in the public sector as a source of higher revenues for better healthcare expenditure.
Okay, sorry, I understand your question now. I was confused by the example of the university fees. Well, yes, you can increase them if you want to, but it depends on what your objectives for the health system are, and you want to increase them in a way that does not undermine the goals of the health system. So you can increase them if you can do it without increasing unmet need for healthcare, if you can do it without increasing financial hardship for households, then you can increase them. But if by increasing them, you are increasing unmet need and financial hardship, then you are going against the goals of your health system. So it's a matter of balancing health system objectives with the instruments that you use to achieve those
I agree,
objectives.
but this caution should be also done when we decide to increase VAT, which are the redistributive effects for the families to increase VAT.
That's true, but then you also have to look at the distribution of the spending. And I think I wouldn't worry so much about VAT and its regressive effect, because if that money is being used to benefit households with low incomes, then it balances itself out. So I wouldn't be worried about using VAT to pay for the healthcare, because the distribution of health spending is very redistributive. So I think you need to look at the revenue raising and the distribution of spending as well.
But the fees can be redistributed too on the public expenditure side.
Exactly, but then take, but then take the. So I think there is also the insurance function, and I think out-of-pocket payments just, it's something that people pay at the point of use. So it's undermining the insurance functions of health systems. So yes, you can take from one person and give to another person, but you want to make sure that if you're taking from this person, you're not preventing them from benefiting from the healthcare that they should have, and that you're not giving disproportionately to people who have more and so on. So it's a matter of balancing these two things. Just on the question of the economic literature on user charges that you raised, if I may just answer this point, because I didn't answer it before. I think the economic and health system literature on co-payments is, the evidence is very clear that co-payments are a very blunt policy instrument if you're trying to reduce inappropriate use of healthcare. So you're just as likely to reduce appropriate use as inappropriate use. And that's why I just don't think it's a good instrument for addressing inappropriate use of healthcare. I mean, there's a lot of different types of evidence, from randomized control trials to observational evidence. But the findings are very consistent, that people are just not good judges of whether something is worth spending on or not. And people are much more likely to listen to what their doctor tells them to do. So there's just a lot of evidence on this, that it's a very blunt instrument, because people don't have the information that they should have, and also are much more willing to be guided by their doctors than we sometimes think. In what way? I mean, I'd be interested to hear more.
Just read the economic surveys about the evidence. Just read Finkelstein. It depends on the design of the copayment. We cannot speak about copayments as a general policy. It depends on the design. We have a recent paper with Bea about how to redesign the Spanish copayment with topping the amount that each patient has to pay. Depends, and it depends on what type of medicines you are making the copayment. Just effective and cost-effective medicines shouldn't have copayment, and there is a lot about that.
Absolutely,
and I think that the health policy conclusion that is a blunt instrument, that's very simple. That's a too simple observation or conclusion about the literature. I can't agree with that.
We can agree to disagree on that. But I think we are aligned in terms of the design. I think the whole point of my presentation, and maybe I went too fast on this because I was out of time, is that the design is really, really important. And so having caps is very protective. So I was not saying that you should not have co-payments. Yeah. I think it's just not always a good instrument for addressing inappropriate use, because some people will experience financial hardship, and that's why it's important to have caps. It's important to have exemptions. I think I agree with you. I think the design is really important. But I think we also need to look at why people are using non-cost-effective medicines or non-cost-effective treatments. And is it just that having a payment is going to actually solve that problem? I don't think it is. I think we need to have other regulations, and we need to look at the root causes of some of these things. So I think we are probably saying the same thing. I will definitely read your paper now, for sure.
Okay. We have time for one or two at the most interventions.
Just to clarify there to Guillem, actually we work with OECD. So they provide us the data and we provide the different reports. So we are currently working with them. And but it's true that what we try to do is to tailor the evidence according to the needs. So the European Commission has requested the state of that, and it's true that uses OECD data, but provided by them to us, and it's similar in the sense of the data of the reports. Yeah. But we try to gather more contextual evidence with our network, etc.
Okay. Ah, no. So, Natalia?
Thank you. Just to change the focus now on the comments, because we have many experts on public financing and co-payments, and of course it's easy to disagree on details here. But I'm curious to ask you to explain how do you deal with the diffusion of your works, and whether you assess somehow what's the impact of all these reports that you develop, that they are thoroughly written and prepared. But I always care about how do they get to the right audience, whether this audience really reads them, obviously, ideally, they use them for improve their policies. So do you have any tools to assess the impact of your reports?
I think, at least for the observatory work, is clear the impact in the sense that we sit with the policymakers. So if there is this request, I mentioned the policy dialogues, but we have also the summer school in different topics. So you know it has an impact because they are listening to it and they are using it for their reports. The future assessment, so it depends. So for my colleagues that are involved in actual reforms, so they have been sitting in Finland with the Ministry of Health. So I guess they will be more able to let you know like what we say or what we discuss, it has been seen in practice. But everything that we do is with the aim to have an impact. And what we try to do is to make the evidence as much, as you can see all these tools of the health reform tracker, etc. For example, we were in a meeting last week with several professors of different universities, and they were speaking about inequalities in health, and they were mentioning, we have all evidence. So they ask us, no, you haven't analyzed it. No, I have. But they don't know how to transfer that knowledge. And it's true that nowadays, more and more you have to adapt and very, very quick or creative in the way you show the evidence to policymakers. So that's a challenge, actually, also for the observatory.
And in WHO, in our work in Barcelona, we have this new platform called UHC Watch, where we make all our research and analysis available to countries there. But we also have a lot of work in policy dialogue events with policymakers across different countries. And we have a training course. We have an annual health financing course here in Barcelona, and we've done this for about 15 years, and we now have probably 1,500 policymakers that we have trained across Europe. And so that's a very important network for us. And we really see that when we work in countries, it makes a difference that people have done our course and been trained with us.
Okay. More? So we will stop here. It's just in time. Okay, so now an applause for her. And now, please, so you can say something on the lunch time or